Good afternoon, all of you, to our annual or our regular environmental health seminar series with UK Cares. I'm Ellen Hahn. I'm the director of UK Cares. We're so happy to see you, and we're excited that Maria's joined us today. I just want to give you a few commercials, reminders that we do have an active request for applications on climate and health out there, and it's due next week. And I hope all of you are writing your rapid response grants as we speak. Also want to remind you that we do have a portal, an online portal. So if you need resources to do your environmental health science, to please use the portal to let us know what you need. And lastly, Kara will be putting these links in the chat, but if you have questions as Maria is talking, feel free to put them in the chat. And at this point, I want to introduce you to Dr. Erin Haynes, who many of you know is our Deputy Director, and she will then introduce Maria. Thanks, Erin.
Wonderful. Thank you, Ellen, for the welcome. And so, yes, I'll also welcome everyone. Thank you for joining us today. We have a very exciting talk and a very special guest, Dr. Maria Argos. So I'll introduce her while she gets ready to pull up her cover slide. Dr. Argos is an associate professor of epidemiology at the University of Illinois at Chicago at their College of Public Health. Her research focuses on arsenic exposure in drinking water, and she is the PI of a study in Bangladesh. She's also a co-investigator of numerous research studies, which she may hopefully allude to during the talk. But we're very excited to have Dr. Argos here with us today. This is a joint seminar with the Markey Cancer Center and the UK Cares P30. So we're delighted to have you here today, Dr. Argos. The floor is yours.
Thanks, Erin, very much for that introduction and for the opportunity to speak with your center today. So as mentioned, my research the last 20 years really has focused on the health effects of metals, predominantly in the area of arsenic epidemiology. So I'll be presenting that work to you first, and then talk a little bit about the work that I'm doing on metal co-exposures currently. So as was mentioned, the vast majority of my work in the last few decades has been related to global environmental health research. This has primarily been conducted in the country of Bangladesh, focused on the health effects of arsenic exposure through drinking water there. So I've been engaged with several cohort studies there. The first is the health effects of arsenic longitudinal study. So I'll be presenting some of our findings from this cohort. This is a cohort that was established and supported for the last 20 years through Columbia University's Superfund research program, and really has provided some of the key dose response data showing health effects of arsenic exposure from drinking water to several chronic disease outcomes, including various cancers and cardiovascular disease. We also, within that same study area, conducted a vitamin supplementation trial among arsenic exposed individuals, looking at the potential primary prevention effects of vitamin E and selenium supplementation for primary prevention of non-melanoma skin cancers in individuals who have had chronic exposure to arsenic. And then finally, I established and serve as the PI of the Bangladesh Environmental Research in Children's Health. And so I'll be talking to you about some of my motivation for doing this work and some of the findings from the cohort that we're currently exploring. So just to give you a brief introduction to arsenic for those who may not be familiar with this element, arsenic is a naturally occurring element. It's a metalloid that's widely distributed in the environment. With respect to its prevalence, it's the 20th most abundant element in the Earth's crust. And we have well-documented exposure to humans to arsenic through various sources. So consumption of arsenic contaminated groundwater has been well documented globally and is probably one of the most predominant sources of exposure to arsenic across the world. But there's also emerging evidence and concern regarding arsenic exposure through consumption of contaminated food sources. So in recent years, a lot of attention has been given to arsenic exposure potentially from rice and rice-based products. Human exposure also occurs to arsenic through contaminated soil, dust, and also air emissions from industry and other sources. There is a robust epidemiologic literature that has shown associations of arsenic exposure predominantly through drinking water sources with several adverse health effects. And this has primarily been shown in the moderate to high dose arsenic concentration ranges. Where the epidemiologic evidence is still relatively sparse is in the low dose range. And also there's existing gaps in the literature with respect to characterizing exposure from sources other than water. With respect to exposures from food sources, as well as other sources, epidemiologic evidence is still rather limited within populations that have had exposure predominantly from these sources. So with respect to the global distribution of known arsenic concentrations in drinking water, it's been shown that there have been identified groundwater sources with elevated concentrations of arsenic across the world, including the United States. Some of the earliest epidemiologic evidence, however, comes from Taiwan, Chile in South America, and Bangladesh. And so I'll be primarily talking about our work in Bangladesh that's contributed to the epidemiologic literature. With respect to arsenic exposure in Bangladesh, it's been documented that the magnitude of this public health concern in the population most severely affects the country of Bangladesh. And unfortunately, the situation arose as the result of a national public health campaign that was conducted in the country beginning in the 1970s. So in a partnership with a number of NGOs and the government of Bangladesh, there was an effort during that time to promote the consumption of groundwater sources in the population as opposed to surface water sources. And so this was in an effort to reduce infant mortality and morbidity from diarrheal diseases in the population. And the campaign was largely successful in accomplishing this result. However, at the time, it was not realized that the groundwater in Bangladesh is naturally contaminated with elevated concentrations of arsenic. So this was only realized after the population had already accrued several decades of exposure from consuming contaminated groundwater sources. And this was realized with the emergence of an epidemic of skin lesions, which are considered a hallmark characteristic of arsenic toxicity. They're also considered a precursor or premalignant lesion to the development of non-melanoma skin cancers. So with respect to the magnitude of the public health issue in Bangladesh, our best data comes from the British Geological Survey study of wells that was done in the early 2000s in Bangladesh. And so through this well survey, they sampled wells across the country and identified that about 27% of the wells had water arsenic concentrations that exceeded 50 micrograms per liter. So at the time, this was the recommended arsenic contaminant threshold for drinking water sources that was recommended by the government of Bangladesh, the World Health Organization, and the US EPA. Subsequently, that threshold was reevaluated and reduced in the early 2000s by the US EPA and the WHO to a maximum contaminant level of 10 micrograms per liter in drinking water for arsenic. So considering that threshold, they observed that about 46% of sampled wells exceeded the threshold of 10 micrograms per liter for arsenic in drinking water. So using census data from 2000 population estimates, this translates to an affected population of about 50 million individuals in the country of Bangladesh. What's interesting is that the geographic variability of arsenic within a defined region tends to be extremely variable. So the map on this slide shows a well survey that was conducted by the Columbia University Superfund Research Program. This work was led by our geochemist Lex Van Geen, who at the time in the early 2000s sampled all 6,000 wells in a 25 square kilometer study region of Arihazar, Bangladesh. So this is a rural area that's about 20 kilometers east of the capital city of Dhaka in Bangladesh. And so at the time that this well survey was done, we saw within this defined geographic area, there was a very large variability in terms of arsenic concentrations in wells that were in relatively close proximity to each other. So what's depicted on this slide is the measured arsenic concentrations for the study area, which ranged from essentially 0 to 1,600 micrograms per liter. So there was evidence that a subset of individuals residing in this area had been chronically exposed to arsenic through their drinking water at exceedingly high arsenic concentration levels. The geographic variability in arsenic within a relatively small area also facilitated the study of nearly a complete dose response for the health effects of arsenic exposure. So we had the capacity to evaluate health effects occurring with low dose exposure as well as very high exposure concentrations. I'll mention this here because this is usually a question that people are interested in when I present this work. So as part of our efforts through the Columbia Superfund Research Program, we did engage the study community in exposure mitigation efforts. So prior to any of our health effects research being initiated, as I mentioned, all wells in the study area were tested for their arsenic concentrations. And then all wells in the community were labeled with their arsenic concentration. And so an example of one of these labels is shown on the slide, which reports the concentration of arsenic, as well as, a very easy to interpret graphic, which basically informs someone whether that drinking water is believed to be safe for drinking water consumption or not. So after this well testing and labeling, the community was engaged in educational programs regarding the potential health effects of chronic exposure to arsenic in their drinking water. And they were encouraged to engage in what we refer to as well switching. So because many of these wells, or essentially all of these wells, are community wells, meaning that they're located outside of individuals' homes, often village areas contain multiple of these community wells. And so we found that there was fairly easy opportunity for individuals to switch from a nearby unsafe well to another well that had a safer concentration of arsenic that was, just as convenient to access. In areas that were relatively sparse of wells that contained safe arsenic concentrations, the Columbia program installed deep community wells. So there's been some evidence to suggest that the concentration in drinking water that's observed from wells is partly the result of the well depth. And so we had the opportunity to install very deep wells in the community that could provide arsenic-free water to regions where no wells were providing safer water. And then around 2007, there was actually a Bangladeshi chemist who is a researcher in the United States who developed a filter called the Sono filter, which removes arsenic from drinking water sources. And so we were able to access and distribute some of these filters to our local study participants. And so participants were able to collect water from tube well sources and then filter their water using these filters in order to be able to reduce the arsenic concentration in their drinking water. And so we did see that as a result of this well switching effort, there was an observed reduction in participants' arsenic concentrations. So what's shown on this slide is in panel A, for individuals that had arsenic concentrations in their drinking water exceeding the Bangladesh threshold of 50 micrograms per liter. What's plotted is their urinary arsenic concentration at the time of the baseline establishment of the cohort, and then at the 2-year follow-up visit. And so we see that many of the participants who had an unsafe tube well identified at the baseline enrollment into the cohort did engage in well switching, and the vast majority of them did switch to a safer well with respect to water arsenic concentration. And so we see a notable decrease in arsenic concentrations over that 2-year period. For comparison purposes in figure B, panel B, I show the urinary arsenic concentrations for individuals that had identified a well that they primarily use for drinking water that had a safe arsenic concentration. And you see that over the 2-year period, their urinary arsenic concentrations remained relatively stable. And so, to suggest that people were appropriately switching from unsafe wells to safe wells, and that we didn't see people from safe wells necessarily, increasing their exposure over that same time period. So with respect to the health effects of chronic arsenic exposure from drinking water sources, the epidemiologic literature has associated this exposure with a number of adverse health effects. Probably the best described are the effects on the skin, so the development of skin lesions as well as non-melanoma skin cancers. Arsenic has been classified as a carcinogen and has been associated with a number of internal cancers. These include bladder, kidney, lung, liver, and there's some compelling evidence to suggest that arsenic may also be a prostate carcinogen. Arsenic is associated with developmental effects in children, similar to the effects that have been observed for lead exposure. In adults, arsenic has also been associated with neurological effects, hypertension and cardiovascular disease, pulmonary disease, peripheral vascular disease, early mortality, reproductive effects, and also diabetes. So based on data from the HEALS cohort, where we had more than 12,000 participants in the rural area of Ari Hazar, that we had, it was about 10 years of longitudinal data on. We were able, in one of the first longitudinal studies to look at individual level arsenic exposure with mortality, show a dose response relationship between arsenic exposure through drinking water with all-cause mortality as well as chronic disease-related mortality. So based on our estimates from the cohort, we estimated that about 21% of the deaths that were observed could be attributed to arsenic exposure from drinking water at concentrations greater than 10 micrograms per liter. And looking at chronic disease mortality, we attributed about 24% of the deaths observed could be attributed to arsenic exposure from drinking water at concentrations greater than 10 micrograms per liter as well. In addition to the chronic disease health effects of arsenic exposure, I've been particularly interested in the health effects of arsenic as it relates to pregnancy outcomes, as well as adverse effects observed in early life. And so we were able to leverage some of the data collected from our study participants, both from the health effects of arsenic longitudinal study cohort, as well as our Bangladesh vitamin E and selenium randomized trial, to be able to look at the effect of arsenic exposure with pregnancy outcomes among enrolled females in those two studies. And so using data that we had available on urinary total arsenic concentrations that approximated the prenatal period. So we didn't deliberately target exposure during pregnancy, but we were able to reconstruct the likely exposure that occurred during pregnancy. We observed an overall association with adverse pregnancy outcomes. And then when we further subset those adverse outcomes, we saw that the association observed was primarily being driven by the association of arsenic with stillbirth births. And so, as I mentioned, I became increasingly interested in the role of arsenic exposure during the in utero period in early life with respect to its health effects across the life course. And so, I think based on a very robust arsenic epidemiology literature that's been observed in adults, there was some absence in the literature with respect to potential health effects among children that we know have been either prenatally exposed or chronically exposed in early life. And so, with some of the emerging evidence from the developmental origins of health and disease, DOHAD work, we know that early life, including in the in utero period, may be uniquely sensitive to environmental insults. And so this became a very compelling area of work for me with respect to arsenic exposure. And some of the work that had been done in this area with respect to other exposures has shown that early life exposure may permanently change the body's structure, metabolism, and physiology, and potentially could promote health or disease outcomes based on these early life exposures later in life. And so this became a very compelling area of interest for me with respect to research in arsenic epidemiology. And really, I think some of the initial evidence within the field of arsenic that supported this was work that was done by Alan Smith's group from Berkeley in Antofagasta, Chile, where basically through a very interesting natural experiment, they had the opportunity to study cancer outcomes in the population that were potentially associated with a very defined period of elevated arsenic exposure for the population. And so what occurred in this region was that in 1957, the drinking water supply for the region was switched to a drinking water source that was unknown to have very high levels of arsenic concentration in that water source. And so between the period of 1958 and 1970, the population consumed water from this drinking water source. In 1970, the arsenic concentrations were realized, a water treatment plant was installed to remove the arsenic from the provided drinking water source, and there was a notable reduction in arsenic exposure for the population. So this provided the opportunity for them to evaluate long-term health effects as the result of that regional exposure to arsenic in their drinking water sources. So in a study that they published in 2010, they showed associations with kidney cancer mortality. And what was very interestingly observed in this study was that they were able to stratify the population based on their birth cohort. So they conducted their analyses stratifying the population into the 1950 to 1970 birth cohort. So this was individuals that would have been exposed either in utero or during early childhood. And they compared this with the population that was born before 1950. So these are individuals that would have been exposed in later childhood or adolescence. And what was observed was that for the birth cohort that had prenatal and early childhood exposure, there was a notably higher increase in kidney cancer mortality as compared to the birth cohort, which was exposed later in life. So again, this pointed to evidence that potentially arsenic during the prenatal period or early life may be a particularly sensitive period for priming individuals to develop certain arsenic-related health effects later in life. So this work really, I think, at the time led to a paradigm shift for the field of arsenic epidemiology, where there was, some change in the focus of hypotheses. And they suggested that, or I think this work suggested that chronic disease risk may really be programmed during sensitive periods of exposure for in utero and early life arsenic exposure. And from a public health perspective, it also suggested that some of our prevention or remediation efforts for adult onset diseases that were being observed in the epidemiologic literature really might be better targeted to sensitive periods in pregnancy, early childhood, or potentially adolescence. Given this motivating research, this led me to establish the Bangladesh Environmental Research in Children's Health Cohort. So up to this point, we had been primarily or entirely focused on looking at the health effects of arsenic among adults. And so through funding from the NIEHS, we were able to establish a cohort of children, which included 500 mothers who are participants of the health effects of arsenic longitudinal study and their offspring. So at the time of the establishment of this cohort, children were recruited if they were between the ages of 5 and 7 years old. And we collected extensive data on both the children and the mothers. So this included questionnaire data, clinical assessment for cardiometabolic traits, growth, as well as a skin examination for the presence of arsenical skin lesions. And then we collected extensive biological specimens from the children and both biological parents. And so while the cohort was initially established to evaluate the health effects of arsenic exposure in children, so as the result of either prenatal or early life exposure, I became increasingly interested in the effect of metal co-exposures. And within the framework of the DOHAD hypothesis, thinking about how early life exposure potentially could lead to adverse trajectories for the establishment of adverse health effects later in life, I became very interested in this idea of biological aging and how this mechanism potentially could explain how early life exposure could set an individual on a trajectory for increased risk of disease development later in life. So from a global health perspective, we know that toxic metal exposures are ubiquitous in our environment, from food sources, water sources, lifestyle and behavioral sources, and industry. So not only arsenic, but we know that there are prevalent exposures from the environment in general communities to cadmium, lead, and mercury. And there is emerging evidence that many of these metals, as well as other environmental factors, can influence biological aging. And so the particular markers of biological aging that I'll be talking about are epigenetic age as well as telomere shortening. So the objective of this initial work was to evaluate using data that we had available from the BIRCH cohort, cross-sectional associations of toenail metal concentrations of arsenic, cadmium, mercury, and lead with markers of biological aging in Bangladeshi children that were aged 5 to 7 years old. And so, as I mentioned, one of the markers of interest is a epigenetic clock. And so just thinking about the construct of biological aging, if we think about aging at the molecular level, we can describe this as the accumulation of cellular damage, which leads to structural and functional abnormalities and decreases the regenerative capacity of cells. And so independent of chronological age, biological aging has been reported to be a risk factor for the development of age-related diseases. So many of the chronic diseases that we can think of, including diabetes, cardiovascular disease, cancers, as well as increased mortality. And so one marker that's been commonly adopted as a metric of biological age is DNA methylation age, or an epigenetic clock. And so this measure utilizes DNA methylation markers, so CpG sites that we would commonly measure as a marker of DNA methylation to represent biological aging of the individual. There have been several epigenetic clocks that have been developed, and nearly all have been highly correlated with an individual's chronological age. There's been some interesting evidence to show that various environmental exposures can accelerate biological aging. And it's been shown that higher DNA methylation age relative to an individual's chronological age is associated with cardiovascular diseases, cancer, and mortality. So the work that has been done on epigenetic aging with environmental exposures as well as health effects has been to date predominantly conducted in adult populations. However, there was a very recent publication by BIRCH et al. That used data from the Helix cohort. So this is a cohort of children residing across 6 countries in Europe. And they were able to use data from about 1,000 children between the ages of 6 and 11 years old to look at various prenatal and early life environmental exposures with epigenetic aging early in life. And so, as I mentioned, there have been various metrics of epigenetic age that have been proposed. These commonly include the Horvath epigenetic clock, or DNA methylation age, as well as several others. So here, what's shown in one of the few publications to look at this within childhood is that the investigators observed fairly strong correlation between each of the epigenetic age measures with chronological age in the study sample. So as I mentioned, the children in this cohort were between the ages of 6 and 11 years old. And I should mention that the Horvath clock specifically was developed essentially using data from individuals from the time of birth to essentially age 100. So this clock was not developed specifically for adults, although has been most commonly utilized in adult cohorts. So with respect to looking at epigenetic aging within children and as it relates to children's health, we really can think of aging as a continuous process that begins early in life. And so we also know that Age-related DNA methylation changes have been observed to occur more rapidly in children than adults. So potentially certain environmental insults or stressors that are experienced early in life may have a more dramatic impact on DNA methylation related changes and potentially a stronger impact on the process of biological aging trajectories early in life. So as I mentioned, there is very limited epidemiologic research looking at this in children. And what's interesting is that the study that was recently published from the Helix cohort was able to show a number of prenatal and early life exposures that were associated with biological aging within childhood. So notably, they observed epigenetic age acceleration with prenatal exposure to maternal tobacco smoking, as well as childhood exposure to indoor particulate matter, parental smoking during early childhood as well. And then interestingly, although not totally clear what the explanation is, they actually observed a reduction in biological aging as the result of other environmental exposures. So these included things like OP pesticides and PCBs. So with respect to the work that we've been doing in this area, we were able to leverage some of our existing study measures from the BIRCH cohort to look at the association between toenail metal concentrations with DNA methylation age in this population. And so we estimated 3 epigenetic clock measures. So as I mentioned, probably the most commonly used measure is the Horvath DNA methylation age clock, but we also utilized 2 others. And so this was the Hannum clock and also the pheno age metric. So using data from about 500 of our participants, as you can see, some of the demographic information is listed on this slide. So we had roughly equal numbers of boys and girls participating in the research cohort. As I mentioned, they were between the ages of 5 and 7. And we had good variability in terms of the toenail metal concentrations in each of the exposures of interest. Furthermore, there was weak to moderate correlation among the different metals, suggesting that there may be different sources of exposure to these various sources. So while we know arsenic is predominantly from drinking water sources, the other exposures may be more dietary based or from other community exposures. So here on the slide, I show the correlation between the calculated DNA methylation ages with the observed or reported chronological age for the children in the cohort. And so I will say that the observed correlations are actually considered to be fairly robust, given that we're looking at a very narrow age range of between 5 to 7 years. So this correlation was actually probably better than what we would have expected given the very narrow age range that we were working with. And then there was moderate correlation among the 3 different clocks, suggesting potentially they're capturing different elements within this early childhood range. So with respect to our findings, they're summarized here. So we observed significant associations with toenail lead concentrations and mercury concentrations with respect to the Horvath DNA methylation age, as well as suggestive associations with arsenic. And then using an alternative metric of biological aging, we observed a significant association of cadmium, toenail cadmium concentrations with the pheno age epigenetic clock. We were also interested in telomere length as a construct of biological aging. There's been a lot of interest in telomere shortening over the life course with respect to development of chronic diseases during adulthood. And so for those who may not be familiar, telomeres are located at the ends of our chromosomes and essentially serve as a protective cap to our genetic material as cells replicate and divide. And so there is a natural shortening that occurs of telomeres with each cell division. However, it's been shown that there potentially could be environmental factors or other insults that accelerate shortening of telomeres. And there's been some evidence to suggest that telomere length may be associated with the development of various age-related diseases. So with respect to telomeres in children's health, we know that telomere biology is particularly interesting during early childhood, since there's a rapid decline in the first 5 years of life in telomere length. And this is because there's a large turnover of highly proliferative cells during this rapid period of growth. So it's thought that potentially telomere length in early life may represent a biomarker of susceptibility to disease later in life for these younger populations. And so again, because of this rapid change in telomere biology early in life, it's thought that potentially environmental insults during the same period may have a more considerable impact on telomere attrition in early life as compared to similar exposures experienced in adulthood. So I won't go too much into detail about this, but usually or conventionally, telomere length has been measured using qPCR, which is a very labor-intensive approach, but in collaboration with a research lab at the University of Chicago, we were able to measure telomere length using a novel assay that they developed based on the Luminex platform. And so we're able to calculate relative telomere length in a very cost-effective manner that, I think hopefully will be employed in larger cohort studies in the future so that we can have more robust data in this area. So with respect to some of the associations that we observed with telomere length, again, we assessed associations for arsenic, mercury, cadmium, and lead, and we observed independent associations of toenail arsenic concentrations and mercury concentrations with shorter telomere length in this young age group. And so when we evaluated whether these associations were independent of each other, it did appear that arsenic and mercury have independent effects on telomere length. We were also interested whether there were sex-specific effects of these associations. And so we conducted analyses stratified by child sex. And we observed that there was a slightly stronger association for the association between arsenic exposure with telomere length among young girls, and that there was a stronger association for toenail mercury concentration with shorter telomere length among boys. So again, this is sort of preliminary evidence looking at this, but we are interested in exploring sex-specific associations further. So to conclude, we observed higher concentrations of toenail lead and mercury independently associated with epigenetic age acceleration based on our measure of the Horvath DNA methylation age. We also observed higher concentrations of toenail arsenic and mercury to be independently associated with shorter telomere length within the same study cohort. So this is some of the limited epidemiologic evidence that exists to suggest that metal exposures may influence biological aging markers in early life. And I think that this is, with respect to future work, important support for promoting the evaluation of aging during early childhood, since potentially we could uncover new evidence to slow down this process early in life and potentially prevent or delay the development of adverse health outcomes as related to metals during adulthood or in the elderly, so as these individuals age. And I'd like to conclude by acknowledging all my collaborators in this work from the University of Illinois at Chicago, University of Chicago, the Columbia University group, in particular, the Superfund Research Program, our collaborators in Bangladesh, as well as collaborators at Dartmouth and the University of Southern California. And I'm happy to take any questions.
Excellent. Thank you, Dr. Argos. That was excellent. We do have a question in the chat, and then I also have one. So Dr. Butterfield asked a very important question about the chemistry of arsenic. Could you back before the aging component about the valent state of arsenic, or was it, he asked also what about organic ligated arsenic?
Yeah, thanks for that question. So when we're talking about arsenic in drinking water, it's primarily inorganic arsenic, so arsenic 3, arsenic 5. We've seen that there's pretty dramatic inter-individual variability in humans' ability to metabolize arsenic. So once inorganic arsenic is ingested, it's metabolized primarily through the action of the arsenic 3 methyltransferase gene. And so we can broadly classify individuals as efficient and inefficient metabolizers of arsenic. For efficient metabolizers of arsenic, inorganic arsenic is readily methylated, which occurs basically through 2 steps. So inorganic arsenic is transformed to monomethylated arsenic and dimethylated arsenic. For individuals who are inefficient metabolizers of arsenic, we know that they kind of get stalled at the monomethylated arsenic step. So they have a larger proportion of that arsenic metabolite as compared to the fully methylated arsenic. So when we're doing work with respect to arsenic concentrations in drinking water, we're primarily talking about inorganic arsenic. When we're looking at urinary arsenic concentration, that's where inorganic and organic arsenic come into play, where typically we're reporting total arsenic, but we need to take into consideration what the distribution of arsenic species is. And there's been, because most of my work is in exposed populations through drinking water, but when we're talking about populations that are exposed from food sources, those individuals may be directly exposed to organic arsenic. And so, this is a concern when we're talking about populations exposed to arsenic through fish and other seafood. And the toxicity of organic arsenic has been generally considered to be basically less toxic. But this has been very difficult, I think, to characterize when we're talking about organic arsenic exposure from rice and other food sources. So hopefully that addresses your question, but a very complicated consideration with respect to arsenic.
Excellent. If he wants more information, he'll pop it in the chat. So I have a question. I want to move over to the aging study, the epigenetic aging. And I might have missed this, but it looked like your data was presented for the children. Is that correct?
Yes.
So did you look at the epigenetic aging of the adults? Because it looked like you had a mom pair study. Did you look at the adults, and what did it look like with them?
Yeah, not yet. So we've published, I didn't present it here, but we've published on the association between arsenic with aberrant DNA methylation in the adults. I just, my my personal interest really right now is in the children, and so that's the data that I've primarily been focused on. We haven't gone back to construct the DNA methylation age measures in the adults, but particularly since we do have data on the mom, it actually would be very interesting to see the correlation between the mother and child.
Yes.
But we haven't had the opportunity to do that yet. Yeah.
All right, that would be very exciting. I'd be interested in that one. All right, we have several other questions. I want to make sure we hit them. Dr. Teresa Fan asks about the underlying mechanism, biochemical mechanism underlying arsenic's acceleration of epigenetic age. And then she'd like to know about the outcome of the vitamin E and selenium trial.
Yeah, so with respect to arsenic's mechanism of action, it's been actually very difficult to characterize, some of the pathways leading to some of the molecular endpoints that we've observed, as well as the chronic disease endpoints. And partly this is because, there hasn't really been a very well-established animal model to study arsenic toxicity. Primarily because, typical mice and rat models metabolize arsenic very differently from humans. So, generally it's been suggested that arsenic is related to oxidative stress, and other factors, but there really is not very well established literature suggesting exactly how this process happens. So, I think some of this, at least within arsenic, is still a bit of a black box.
So that would be a potential, sorry, this is Teresa Fan jumping in. That would be potentially an area of research that would help probably with mitigation issue. If we can understand the underlying biochemical mechanism, we might be able to mitigate that acceleration. Is that a right way of thinking of it?
Yeah, absolutely. Absolutely. And it's been, a very difficult to show with arsenic. And I think there's some hope, at least, leveraging some of the genetic information that's known, given that there's a gene that at least very clearly is associated with arsenic metabolism. So thinking about how to leverage that information as well for, prevention or remediation or screening.
Yeah, we have some idea. You and I would be talking this afternoon. Maybe I'll toy some idea with you, see what you think.
Yeah, would love to. Sounds great.
Yeah, and I'm actually very interested in the vitamin selenium trials. It's been used a lot in the cancer field, and it's the results highly controversial. First of all, I'd like to ask, what kind of selenium supplement did this study actually use?
Yeah, it was L-selenomethionine.
It's actually selenomethionine. Okay. Do you have any outcome from that study?
We do. So we're actually trying to publish that work now. But essentially we did not see, at least for the primary prevention of non-melanoma skin cancer, we did not see enough. This was a 2x2 trial. So we had people randomized to vitamin E, selenium, and then combination vitamin E, selenium, similar to the SELECT trial that was done. And so for our primary endpoint, we didn't find any efficacy of the treatment on that endpoint.
Yeah, that's interesting. That's the same kind of conclusion coming out of the cancer SELECT trial. In fact, in lung cancer, they actually somewhat accelerated lung cancer development. And we actually have molecular evidence that selenomethionine is the wrong form to use, because in our animal study, silumethionine actually accelerates lung cancer development with smoke-induced lung cancer. So other species like selenite, organic species, and also a prodrug called methylselenic acid actually has better efficacy. So something we can talk about it too, because the molecular mechanism differ among silumethionine and these other two forms. And it's not surprising that silumethionine does not work.
Thank you, Dr. Fan. I'm glad you're meeting with Dr. Argos later, hopefully today, to follow up on that. That's exciting conversation. I know Dr. Munker, you had a question I want to give.
Nice talk, Dr. Argos. Are you actually on campus in Lexington? No, Zoom.
If you could get a little closer to your microphone, we're having trouble hearing you.
A question which you may expect is, as hematologist, we commonly treat promyelocytic leukemia with arsenic, and the patients obviously know about the risk of cancer. Are there any data in patients who got treated for leukemia with arsenic trioxide? Would this be of interest for your research?
So I think actually some of the early, case reports on the carcinogenicity of arsenic came because of arsenic's use as a therapeutic compound. But it is actually of interest to, think about what are the, outcomes within individuals that have been treated with arsenic-related drugs. And I'm not aware of any research that really has followed that type of population, but it's a very interesting question.
What I know from the literature is that the arsenic levels in patients who are treated for with arsenic trioxide, they decrease rapidly. So what I heard or saw somewhere, it cannot be measured. So you're talking for the children, or you talk about a lifetime exposure?
That's right. It's a chronic, long-term, relatively high dose exposure.
But it might be interesting to get you samples from patients being treated.
Yeah, that's right. That's right. And I don't know that's been done, but I agree.
Okay, thank you.
And Ellen, would you like to ask your question live, or I'm happy to read it also?
Sure. Hey, everyone. Maria, that was amazing. I just kept thinking about intervention research, and that may not be what you're doing right now, but is anyone at your team thinking about developing and testing kind of tailored or targeted kinds of environmental health interventions? Because to me, your work is a perfect example of what I think Bob Wright would call environmental precision medicine, or environmental precision, or precision environmental health, meaning, it's clear from your work, or at least preliminarily, that we need to be intervening younger, with prenatally as well as children, because I know in some places in the country, physicians, for example, are doing environmental health assessment with children and parents, but there's so much we need to do. And so I just want to see what your thoughts are in terms of on the intervention side, and what maybe your longer term plans are.
Yeah, thanks for that comment. So it's in terms of intervention, ultimately, because our discipline is public health. This is the ultimate goal of the work that we're doing. I think we've been thinking about potentially how to leverage some of the genetic information. We've seen from the work that was done in South America, early life exposure that is fully remediated, or essentially fully remediated, still has long lasting health effects. So remediation alone is not enough. Obviously the antioxidants that we evaluated, were not successful in this context for reducing risk, but, potentially considering other preventive agents earlier in life, or, looking at individuals who are genetically susceptible and maybe engaging them in more rigorous screening. So I think, it's a very complicated picture still, given that exposure is still pervasive in the country. So I think, our first goal really is to stop exposure, reduce exposure, and then, think about how we can reduce risk in populations that have been already exposed. But within the US context, I mean, many have advocated for, environmental screening of women prior to pregnancy, early in pregnancy, and it is amazing to me that that hasn't been adopted. I think that's critically important to the health of future generations. So, I think something that we definitely should advocate for.
Excellent. Well, we will end on that note. We are at time. And Dr. Argos, we really want to thank you for attending today, being a part of our seminar series. Thank you so much. And we're looking forward to the various meetings we have scheduled with you, because we would love to learn more about what you're working on and how we might be good partners and collaborators with you.
Sounds great. Thank you so much for having me.
Thank you.
Thank you, Maria.
Bye. Thanks.